Okay, well, let's go on then. Are you ready, Alexandre Petit? Alexandre is from the group of Guy Rimbaud, so that's going to be high quality, and he's going to do two talks, one on the long-term results of the Malingue technique in the surgical treatment of Dupuytren's disease, and then he's going to go on with the middle phalangoectomy with shortening fusion of the fifth finger in Dupuytren's digital hooks. It's not 7 minutes, it's 14 minutes. Go ahead, Alexandre.
So, dear colleagues, I'm not Thomas Albert. He's one of our fellows. He couldn't be there today, so I'm the one presenting this study, which was his medical thesis. I will be presenting the long-term result of using of the malingplasty in the surgical treatment of Dupuytren's disease. There are many possible surgical approaches for Dupuytren's disease. The malingplasty is one of them and was described in 2002 by a French surgeon. It's actually a modification of the Z-plasty, to which two counter incisions have been added. What's great about this technique is that the flaps have better blood supply and the neurovascular bundles are easier to access. Our team studied and published a detailed description and mathematic model of the technique. So this was a single-center retrospective study of patients operated on in our center, which were followed up after more than 5 years. The main objective of the study was to assess the recurrence rate using the criteria of both Caroline Leclerc and Felici. All patients had been operated on by the same highly experienced surgeon. So what about the results? 55 patients were included in the study. Results were good, especially for the middle finger and the ring finger. Only the little finger showed a significant loss of correction. All preoperative deformities were corrected postoperatively. There were no postoperative complications, whether in terms of skin necrosis or iatrogenic injury to the neurovascular bundles. No infections or hematoma were reported. Mean quick DASH score was good, and the overall Michigan questionnaire score was excellent. In terms of recurrence, our series shows an overall acceptable recurrence rate comparable to the best series in the literature. According to Caroline Leclerc criteria, the recurrence rate was 50%, which is comparable to an earlier series by Fouché. According to the more widely accepted criteria by Felici, the recurrence rate was less than 30%, which remains acceptable compared to other series in the literature. According to the more widely accepted criteria, the aesthetic and functional results are also very satisfactory compared to the other series. The absence of complication in our series shows that this technique is reliable when performed by an experienced surgeon. Of course, our series has its strengths and weaknesses. The main strength is that the first series to study this specific technique with a long follow-up. Although malingplasty did not improve the recurrence rate in Dupuytren's disease compared with other techniques, its advantages in terms of functional improvement and complications make it an interesting surgical option. So try this technique, publish your results. you'll see it works great.
Your question? Who was the experienced surgeon who did the procedures?
Jan Sinka, it was
Jan Sinka, yes. Okay, thank you. All right, let's go on. Next talk.
It's me. So in this new presentation, I will talk about shortening arthrodesis with resection of the complete middle phalanx in digital hooks caused by Dupuytren's disease. The surgical technique was described in the 90s by Guy Rimbaud, former president of the French Society and now a pioneer of the EFSH. He is my mentor and is also my friend. Dupuytren's disease remains a therapeutic challenge, particularly in the management of severe digital contractures. For the little finger, we propose a shortening arthrodesis with complete removal of the middle phalanx. In our team at the Hunt Center in Angers, we reviewed 33 patients who underwent surgery using this technique. In the vast majority, it was for recurrent disease, but for 6 cases, it was a first intention treatment. These were patients with a significant extension deficit, mostly classified as stage 3 or 4 according to the Tubiana classification. In this video, we can see schematically how the procedure is performed. We use a dorsal approach. Then, after resecting the middle phalanx, we perform the arthrodesis, which is secured with car wires. We prefer an H-shaped incision for skin management, but a longitudinal approach is also possible. For fixation, a centromedullary screw is also an option, but we prefer using Kirschner wires to allow for removal of the hardware. The procedure is straightforward, and we deliberately choose not to affect the palmar side of the little finger. After excluding deceased patients and those lost to follow-up, we were able to reevaluate 25 patients, which corresponds to 27 cases. The vast majority of patients were satisfied or very satisfied. 1/3 of the patients reported pain in cold condition. Bone consolidation occurred in 2/3 of the cases, while the other cases were in tight non-union without clinical impact. The vast majority of patients were able to shake hands and wear gloves. The grip of large objects did not present any particular issues. Obviously, due to the stiffness of the little finger, it was more difficult to grasp small objects. Of course, there are alternatives to this procedure, but a satisfactory functional outcome and a very satisfactory aesthetic results were noted, even in women. In conclusion, this is a very interesting solution. Before that, it was a complex problem for which amputation was the only alternative. This approach provides a functional and aesthetic results and preserves the fingertips' sensitivity. The social use of the hand is fully possible after this surgery. So don't hesitate to try this simple technique. Thank you.
Okay, Dr. Eaton, you have a question.
In the patients who, those are great presentations, thank you very much. In the patients who lost some sensitivity in their fingers, did you measure sensitivity preoperatively?
No, because it was recurrence cases.
Okay. They may not have had it to start with.
Thank you very much. Nice presentation. I was wondering, since we also have heard that you can remove the middle phalanx without the arthrodesis, why would you bother to do an arthrodesis in the first place? Why not try to remain some movement in the joint?
It's a possibility too.
Pourquoi est-ce que tu vas aller te faire chier à faire une arthrodèse alors que tu peux simplement resséquer la deuxième phalange et mettre une broche? Pourquoi est-ce que tu n'évoluerais pas vers ça? Faire une simple comme tes boules l'a fait.
Yes, it can be a possibility. Why not? But I think it's a good thing. So I don't know.
Did you do it on other fingers?
No.
No. I wouldn't suggest it because I did it on a middle finger. I have never seen such an unhappy patient. Okay. Was there any question about the Malang technique? The flap technique? Nobody? Oh, thank you, Alexander.
Yep,
Thank
thank
you for
you.
your presentation.